Okay, hello everyone. I'm glad to see you on second part of my lecture related to pharmacology of autonomic nervous system, and today we continue our discussion about ANS pharmacology, and we'll talk about organs. We'll talk about organs, about localization of different receptors and effects that we may have or which occurs after stimulation or inhibition of these receptors. So, let's start. Also, please let me know about quality of this translation. What about picture? What about sound? If you're able to hear me, and if everything is fine for this translation, please write your comments in the chat. Also, if you will have questions, please let me know in the chat. I will try to answer all of them. Okay. So, the next organ that we are going to continue, or something happened with my iPad. I can't see. Just a moment. It's a technical issue. We will try to fix it very quickly. Hold on a minute. Sorry about that. Okay, so now everything looks fine, and we are ready to go. Okay. Yesterday we finished with eye pharmacology. We finished with aqueous humor production, and now let's talk about kidneys. Let's discuss type of receptors in the kidneys and effects which occurs after stimulation of these receptors. In general, maybe you know, maybe you don't know, maybe you will know right now. Kidneys have one type of receptors. This is beta 1 adrenergic receptors. Beta 1 adrenergic receptors. This should look like a kidney. Looks like a kidney, behaves like a kidney. So most likely it is a kidney. In the kidneys, we have beta 1 adrenergic receptors. Where these beta 1 adrenergic receptors are located? They located in juxtaglomerular cells. In response to stimulation or after stimulation of these beta 1 adrenergic receptors, I'm drawing plus here, beta 1 adrenergic receptors, or in response to activation of sympathetic nervous system. And where does sympathetic nervous system live? It lives in adrenal medulla, right? So we have epinephrine, norepinephrine, or by activation of kidney sympathetic nerves or kidney sympathetic fibers, juxtaglomerular cells release what they release. They release renin. And renin is a major enzyme in renin-angiotensin-aldosterone system. We know, right? So renin converts angiotensin again to angiotensin 1. After that, we have ACE enzyme that converts angiotensin 1 to angiotensin 2, and angiotensin 2 interacts with angiotensin receptors, type 1 receptors for angiotensin 2, and these receptors located in many places, and one of them, it is adrenal cortex and vessels. So in response to renin releasing, we have activation of renin-angiotensin-aldosterone system, and as a result, we have rising in blood pressure, we have vasoconstriction, and we have fluid retention, and this causes expanding in blood volume. So please remember beta-1 adrenergic receptors in the kidneys, and we also should assume, we should know, right, that beta blockers they block these beta-1 adrenergic receptors, and doesn't matter are they selective or not selective, they block these beta-1 adrenergic receptors. So in the kidneys, beta-1 adrenergic receptors, but not everything is so easy with the kidneys, as we said only one part, one part of this chain. We said receptors on juxtaglomerular cells. But now let's say a few words about glomerulus, and let's say a few words about vessels and glomerulus. So we know that we have kind of glomerulus, and we have two vessels, right, in glomerulus. Here we have Bowman's capsule, drawing it like that. So we have two vessels. The first one is a vas afferent, and second one is a vas efferent. And you see that diameter of these vessels are different, right? Because diameter vas afferent greater, and diameter of vas efferent is smaller. I will try to move my camera in another place, like that. So vas efferent is smaller, and very important to understand type of receptors that are really present in the vas afferent and vas efferent, because many questions, many concepts are focused on that. So vas afferent and vas efferent both have alpha-1, they both have alpha-1 adrenergic receptors. More for vas afferent, so let's make it bigger. Alpha-1 adrenergic receptors. Bigger, and vas efferent has smaller amount of alpha-1 adrenergic receptors, and we know that alpha-1 adrenergic receptors, they copulate with GQ proteins, and they respond. They have like a second messengers, inositol triphosphate and diacylglycerol, and result of activation of alpha-1 adrenergic receptors, the calcium releasing and vasoconstriction. So in case of activation of sympathetic nervous system, we have vasoconstriction of vas afferent and vas efferent, and as a result, renal blood flow decreases. Yeah, renal plasma flow decreases. But what we should keep in mind? We should keep in mind that was afferent has D1 receptors. What does it mean, D1 receptors? It's dopaminergic receptors type 1. In general, we have 5 subtypes of dopaminergic receptors, and many of them are located in the central nervous system, but at the periphery we have D1 receptors for dopamine. Yeah, dopaminergic receptors. And activation of these receptors causes relaxation of was afferent. Relaxation. D1 adrenergic receptors coupled with GS proteins. Yeah, with GS proteins. Let's put this D1 receptors here. D1 receptors here. Activation of them stimulates GS, stimulates adenylate cyclase, and converts ATP to cyclic adenosine monophosphate, and this causes relaxation and smooth muscles. Two important medications we should keep in mind. Dopamine, of course, and another one, phenaldopam. So phenaldopam and dopamine, they stimulate dopaminergic receptors, and as a result we have dilation of afferent arterioles, and they used in order to improve patient condition in case of shock, in case of shock of different etiology, a cardiogenic shock or another one. So activation of D1 receptors causes vasodilation. So stimulation causes vasodilation. Third type of receptors that present in was afferent, the prostaglandin receptors. And prostaglandins are maintaining was afferent diameter. Yeah, so they increase was afferent diameter, and they have vasorelaxant properties. So they increase diameter of was afferent, and also related to vasodilation. So prostaglandins, they increase renal plasma flow, because they dilate was afferent. Yeah, they increase renal plasma flow, and as a result they increase GFR, glomerular filtration rate, with no significant changes in filtration fraction, because both of renal plasma flow and GFR are rising. What is important? Important that patient with or patient who taken non-steroidal anti-inflammatory drugs, NSAIDs, like aspirin, like ibuprofen, and other one, may have hypertension. What is the genesis of this hypertension? We know that non-steroidal anti-inflammatory drugs, they block prostaglandin synthesis, yeah, because we have two pathways. We have One pathway is COX-1 and COX-2 pathway related to production of prostaglandins and thromboxanes, and another pathway is 5-lipoxygenase pathway for leukotriene production. So administration of non-steroidal anti-inflammatory drugs decreases prostaglandin production, and as a result less amount of prostaglandins present, and this causes constriction of vas afferent. In response to constriction of vas afferent, we have decrease in renal blood flow and renal plasma flow, and really juxtaglomerular cells they respond to that and increase renin secretion. As a result, we have rising in blood pressure. Yeah? So administration of non-steroidal anti-inflammatory drugs in some individuals may cause rising in blood pressure. So we done with vas afferent. What about vas efferent? A little bit corrected. And vas efferent, we said we have alpha-1 adrenergic receptors, but they're not so significant, let's say, like in vas afferent, yeah, less significance. Another type of receptors that we have in vas efferent is a AT1 receptor. So it is a angiotensin receptors type 1 for angiotensin 2. So AT1 receptors for angiotensin 2. Once again, receptors for angiotensin 2 type 1. As we have production of renin, yeah, by juxtaglomerular cells, and we have activation of renin-angiotensin-aldosterone system. The final result, we have synthesis of AT2 angiotensin 2, and this angiotensin 2 acts on this angiotensin type 1 for angiotensin 2 receptor. So stimulation of these receptors causes vasoconstriction. Not only in vas efferent in kidneys, but in general in our organism. Yeah? In our organism. So we have vasoconstriction. As a result, we have decreasing in vas efferent diameter, glomerular filtration rate rises, renal plasma flow decreases, and filtration fraction also increases. Yeah, maybe it looks like a controversial for activation of sympathetic nervous system and renin releasing, because we have activation in case of fight and flight response, or in response to stress. Yeah, as we're talking about sympathetic nervous system, and let's say bleeding. Yeah, in case of bleeding, we have activation of sympathetic nervous system. We have activation of renin-angiotensin-aldosterone system, and we have releasing of arginine, vasopressin, or antidiuretic hormone, or vasopressin, and it looks like everything should be focused on conserving of fluids, yeah, and maintaining of blood volume. But it happens because due to the constriction of vas efferent, we have more osmotically active filtrate, and more reabsorption has happened. So this is the mechanism how it works. Yeah. So we have AT type angiotensin type 1 receptors for angiotensin 2 and vas efferent. And what is interesting that we have medications that called angiotensin converted enzyme inhibitors, and we have ARBs, angiotensin receptor blockers. ACE inhibitors and ARBs, they block these receptors. As a result of this as a result of this blockade, we should understand that diameter of vas efferent rises, yeah, increases, and this may cause may cause kidney insufficiency in some individuals, especially with bilateral renal artery stenosis, as kidney unable to maintain glomerular filtration pressure due to that. So administration of ACE inhibitors and ARBs may cause rising in creatinine level also, and usually rising in 15 to 20% from basic level of creatinine is a normal situation with administration of ACE inhibitors and ARBs, and greater rising corresponds to pathological situation. So I hope this is clear, this is understandable. If you have questions, please write your question, type your questions. Let's continue. Few words about urinary bladder. Urinary bladder. What kind of receptors are here, and how it works really, yeah? Let's talk about male urinary bladder, because let's put a prostate gland here. Prostate. So we'll discuss prostate also. So what we have? We have internal sphincter, and we have external sphincter. This internal sphincter is under involuntary control. Yeah, it's controlled by autonomic nervous system, and we have alpha-1 adrenergic receptors here. So activation of sympathetic nervous system stimulates alpha-1 adrenergic receptors by releasing norepinephrine, and as a result we have constriction of internal sphincter and urinary retention. Yeah, urinary retention. Also we have external sphincter. External sphincter, and this external sphincter under voluntary control. And we have an M subtype of receptors. This is like skeletal muscles, yeah, an M subtype of receptors innervated by somatic nervous system, by somatic nervous system. What else? We have cholinergic inputs. And we have adrenergic inputs to the bladder. From cholinergic side, we have M2 and M3 types of receptors, and activation of cholinergic inputs, let's say activation of parasympathetic nervous system, yeah, causes contraction contraction, and finally voiding, right? Voiding. What about adrenergic? Adrenergic is a sympathetic nervous system, and we know that sympathetic nervous system responsible for for fight and flight response, and it is no time for voiding during the stress. During the stress. So we have beta 2 adrenergic receptors here, and beta 3 adrenergic receptors recently were described here, and activation of beta 2 and beta 3 receptors are responsible for relaxation, or let's say storage phase of the urine. Very interesting that we have Cholinergic receptors here also. They call P2X1 receptors, and urothelium, the cells, releases additional relaxing and constricting factors, and these additional relaxing and constrictor factors might be ATP, and ATP acts on this type of receptors, also participating in contraction. And also urothelium responsible for nitrous oxide releasing, and responsible for prostaglandins releasing, and this causes relaxation, as we should understand, relaxation. So what we have as a summary of innervation of urinary bladder, and what kind of receptors are here, and what kind of inputs present here. First, we have cholinergic system, parasympathetic nervous system, and parasympathetic nervous system responsible for voiding, responsible for urination. Activation of parasympathetic nervous system causes contraction of musculus detrusor urine, and responsible for voiding. Again, activation of M2 and M3 receptors causes contraction of the bladder, contraction of the musculus detrusor urine, and relaxation of sphincter, especially relaxation of internal sphincter, because external sphincter is under voluntary control, but relaxation of internal sphincter is important, so it's kind of antagonistic relations. We have adrenergic inputs from sympathetic nervous system, and activation of sympathetic nervous system causes relaxation, responsible for relaxation, responsible for storage, beta 2 beta 3 receptors, and also increases internal sphincter tone in order to prevent leaking of the urine. Also we have nitroergic system, with nitrous oxide, tragic system, and also it was described that in the urinary bladder we have a peptidergic system. So again, let's recap. Voiding, stimulation of M3 receptors, stimulation of M2 receptors, stimulation of P2X1 receptors, and inhibition or blockade of alpha 1 adrenergic receptors, and relaxation of skeletal muscles, blockade of NM receptor, decrease in impulsation, let's say, not blockade, decrease in impulsation. What about storage? storage or accumulation of the urine. Or we have inhibition of M3 receptors, less impulsation. Yeah, let's say M2 receptors, less impulsation on P2X1 type of receptors, and stimulation of alpha-1 adrenergic receptors, and activation of NM receptors. Let me say a few words about prostate gland. We know that prostate gland has alpha-1 adrenergic receptors. Where these alpha-1 adrenergic receptors and are really in the prostate or the somewhere else. Let's say that they somewhere else, they in the capsule, capsule, the prostate glands and smooth muscle cells, alpha-1 receptors. So in case of BPH, benign prostatic hyperplasia, in case of BPH, we have increasing in size of the prostate, and what happens that prostate pushes on urethra, pushes in case of BPH. We're using one kind of medication that might be used, is alpha blockers or alpha receptor blockers, alpha receptor antagonists. What kind of receptors? What kind of drugs? Prazosin, let's say, doxazocin, etc. Administration of these medications relaxes prostate capsule, and as a result of this relaxation, we have less pressure on urethra and facilitated voiding, or urination. Also, let's say a few words about overactive bladder. Let's say in case of cystitis. In case of overactive bladder, we use muscarinic antagonists. Why muscarinic antagonists? Because their action will be similar. To action storage phase, right? So we have blockade of muscarinic receptors, and we decrease excitation. But again, let's keep in mind that this is therapeutic usage, and overdosage of muscarinic antagonists may cause urinary retention. So they may cause urinary retention. And the second situation, when we have hypoactive bladder. In case of hypoactive bladder, we use muscarinic agonists in order to stimulate, muscarinic receptors. So generally, it is one of major targets for that. Okay, I hope that everything is understandable with urinary bladder, with kidneys. Just would like to check stream health. Everything is fine. Yes, everything is fine. Everything is going well. So let's go next. Next, let's discuss lungs. And of course, next couple minutes we will talk about lungs, but please keep in mind that we will talk about smooth muscles in the lungs. Yeah. So just a moment. Smooth muscles in the bronchoalveolar tree. So we have bronchi and we have lungs. What kind of receptors we have in the lungs? In the lungs we have two types of receptors, M3 receptors and beta 2 adrenergic receptors, M3 cholinergic receptors and beta 2 adrenergic receptors. Please don't think that right lung has M3 receptors only and left lung has beta 2 adrenergic receptors only, both of them present in each lung, just to split, to separate parasympathetic and sympathetic nervous system, and for better understanding. So activation of M3 cholinergic receptors causes bronchoconstriction. What kind of drugs we have? We have methacholine, that uses for bronchoprovocation test, and we have acetylcholine esterase inhibitors, like rivastigmine, physostigmine, donepezil, and other one. So activation of M3 receptors causes bronchoconstriction. Why bronchoconstriction? Because on smooth muscle cells we have M3 receptors, and activation of them causes contraction of smooth muscles and causes bronchoconstriction. Also, we should keep in mind that M3 receptors present in the glands, and activation of M3 receptors also increases secretion of bronchial glands. Blockade of M3 receptors causes bronchodilation. What kind of medications? Let's say atropine as a prototypic agent, and let's say ipratropium, and tiotropium bromides. And also blockade of M3 receptors inhibits secretion. What about, so this was about parasympathetic nervous system. What about sympathetic nervous system? In sympathetic nervous system, blockade of beta 2 adrenergic receptors causes bronchoconstriction. When we have blockade of beta 2 adrenergic receptors, in case of administration beta blockers, and really, of course, selective beta blockers like metoprolol, they are preferred yeah, in patients with bronchial asthma, let's say, but their selectivity is relative, and in case if dosage rises, they also able to block beta 2 adrenergic receptors even if they selective. So let's see propranolol here. Propranolol. And stimulation of beta 2 adrenergic receptors causes bronchodilation. Bronchodilation. Stimulation with beta 2 agonists. And these drugs are very useful for control, for prevention of bronchial asthma attacks. Yeah. So what kind of medications? Let's say albuterol. Albuterol and salmeterol. So that's it about lungs. Few words about GIT, gastrointestinal tract. GIT. Two important things we should remember for gastrointestinal tract. The first idea is a peristalsis control, and the second idea the sphincters, control of sphincter tone. As we stimulate peristalsis, we should understand that food should passage through, and this should decrease sphincter tone, and vice versa. As we have stimulation, as we have inhibition of peristalsis, we should increase sphincter tone. So what we have in sphincters? In the sphincters, we have alpha-1 adrenergic receptors. Yeah. Alpha-1 adrenergic receptors, and increasing in sympathetic nervous system tone decreases peristalsis and stimulates alpha-1 adrenergic receptors, increases sphincter tone. And we have beta 2 adrenergic receptors. Stimulation of beta 2 adrenergic receptors causes a relaxation. So stimulation of beta 2 causes relaxation and decreasing in peristalsis. And stimulation of alpha-1 adrenergic receptors causes contraction and increases sphincter tone. Also, we have M3 receptors, M3 subtype of receptors, and activation of M3 receptors increases peristalsis and increases secretion. And we should understand that innervation here is kind of balance between sympathetic nervous system and parasympathetic nervous system. Yeah, so if we have activation of sympathetic nervous system, we have inhibition of parasympathetic nervous system. Okay, next, glands. What we should say in general about glands. M3 receptors, we have activation of M3 receptors increases secretion, and blockade of M2 receptors decreases secretion. If we're talking about salivary glands, you know that we have vessels, right, that come in to the glands, and inside vessels, now we will talk, we have alpha-1 adrenergic receptors. So activation of sympathetic nervous system with norepinephrine causes constriction of vessels, and less fluid coming to the glands, less blood coming to the glands, and this decreases secretion also. Also inside salivary glands we have beta-2 adrenergic receptors, and stimulation of beta-2 adrenergic receptors decreases water amount in the salivary glands. It's not so crucial to know, but it would be nice if you will know that. Decreases water amount, decreases electrolytes, increases amount of mucin and proteins, and increases amount of salivary enzymes, and everything, all these things cause production of thick and viscous saliva. Stimulation of M2 receptors has opposite effects, and more water coming into the saliva. So we have greater amount of water there. A few words about adipose tissue. Adipose tissue. And adipose tissue, let's draw adipocytes here. We have beta-3 adrenergic receptors, and these beta-3 adrenergic receptors, they are responsible for lipolysis. So we have production of glycerol and fatty acids. Stimulation of beta-3 adrenergic receptors stimulates lipolysis and production of fatty acids and glycerol. Also, a few words, let's say, about liver. What we have inside the liver, we have beta-2 receptors, and you know that liver is a storage of glycogen, and we have breakdown of glycogen and getting glucose, and this process called glycogenolysis. And also liver is able to utilize lactic acid, glycerol, and amino acids in order to synthesize glucose. And this process called gluconeogenesis. So stimulation of beta-2 adrenergic receptors stimulates breakdown of glycogen and stimulates gluconeogenesis. glycogenesis, and this increases glucose level in the bloodstream, and this is important for fight and flight response. It's important for stress. Okay, important for stress. Next, let's say a few words about male and female reproductive system. Male reproductive system. We see that in the prostate we have alpha-1 adrenergic receptors, right? And blockade of these alpha-1 adrenergic receptors has a therapeutic effect for patient with BPH, but also in epididymis. We have alpha-1 adrenergic receptors in vas deferens. We have alpha-1 adrenergic receptors in seminal vesicles. Alpha-1 adrenergic receptors and prostate, let's put it again here, alpha-1 adrenergic receptors. Stimulation of these receptors or activation of sympathetic nervous system are responsible for ejaculation. And activation of parasympathetic nervous system responsible for erection. And now we will talk in few minutes why that happens, because we have vasodilation there, right? What about female reproductive system? Female reproductive system. Of course, we talking about uterus. We're talking about uterus, and in the uterus we have alpha-1 receptors, and if we do not have pregnancy, activation of alpha-1 adrenergic receptors causes contraction. But if we have fetus inside, uterus expresses beta-2 adrenergic receptors, especially in the end of gestation. And stimulation of beta-2 adrenergic receptors causes tocolytic effect, causes a relaxation of uterus, and this medication is called tocolytics. Tocolytics, because they stimulate beta-2 adrenergic receptors. What kind of medications? Terbutaline and ritadrine. So these medications are useful to prevent premature labor contraction. Okay. Next, let's say a few words about platelets. Platelets. On the platelet surface, as we're talking about autonomic nervous system, we should mention alpha-2 adrenergic receptors and stimulation of alpha-2 adrenergic receptors by epinephrine, by norepinephrine, that present in the blood in the plasma, blood plasma, causes platelet aggregation. Stimulation by epinephrine, norepinephrine, are responsible for platelet aggregation. But also, just to let you know, platelets have another type of receptors, like receptors to thromboxane A2. They have receptors to ADP, adenosine diphosphate. They have receptors to serotonin, 5-hydroxytryptamine receptors. They have receptors for platelet-derived aggregation factor, and also they have GP1B receptors for von Willebrand factors, and they have GP2B3A receptors for fibrinogen. So many of them. But as we're talking about autonomic nervous system, we should mention here alpha 2 adrenergic receptors, right? Pancreas. We will not talk about whole process of insulin secretion and stimulation and inhibition of insulin secretion. We will not talk about all these mechanisms. Just would like to let you know that in the pancreas we have as minimum 2 types of cells. We will cover here. We have alpha cells and beta cells. So alpha cells responsible for glucagon secretion, and beta cells responsible for insulin secretion. Very interesting that in case of stress, right, in case of fight and flight response, we have releasing of epinephrine and norepinephrine to the bloodstream. And we say that in terms of liver increases a level of glucose, right? And we know that during running, during physical work, skeletal muscles, they are not sensitive to insulin action, so they just need a high glucose level, in order to run somewhere in case of stress. So what is interesting that both these cells, alpha cells and beta cells, they have alpha 2 adrenergic receptors. Now, alpha 2 adrenergic receptors, and epinephrine acts on both of these receptors. But in case of alpha cells, stimulation of alpha 2 adrenergic receptors stimulates glucagon secretion, glucagon production. And in case of beta cells, stimulation of alpha 2 receptors inhibits insulin releasing. So as a result, we have rising in blood sugar level. But stimulation of beta 2 adrenergic receptors stimulates insulin production. Also stimulation of M3 receptors stimulates insulin secretion. But here's the interesting thing, that we see that epinephrine produces action on alpha 1, alpha 2, beta 1, and beta 2 receptors. But in case of beta cells, epinephrine acts preferentially on alpha 2 receptors and less likely on beta 2 adrenergic receptors. So the final effect is an inhibition of insulin production. Okay, so we're almost done, and the only one organ we should discuss is the heart, and we should talk about cardiovascular system, heart. So what we should say about heart, and this is the heart. Inside the heart we have sinoatrial node, yeah, like a conductive system, and AV node. Sinoatrial node and AV node. Sinoatrial node and AV node, they are under parasympathetic nervous system control with nervus vagus. And of course, heart receives sympathetic nerves from sympathetic nerve system. But major innervation is a innervation by nervus vagus of parasympathetic nervous system for sinoatrial node. So, as we're talking about sinoatrial node, inside the sinoatrial node we have M2 and beta-1 adrenergic receptors. Inside the AV node we also have M2 and beta-1 adrenergic receptors. And as you know, probably, the heart has beta-1 adrenergic receptors. When we're talking about beta-1 adrenergic receptors, we should keep in mind that these beta-1 adrenergic receptors located in the mid of the heart or in the myocardial ventricles, yeah, in the heart ventricle. So what we have and which effect of stimulation we have. Let's draw action potential in this in the sinoatrial and AV node. So we have kind of a resting membrane potential is around minus 60 millivolts, and we have threshold level is around minus 50 millivolts, but in different books you can find a different information. And the cells in the sinoatrial node and cells in the AV node, they really never reach this resting membrane potential, because we have a process that called slow diastolic depolarization. So action potentials look like that, right? Look like that. So we have phase 4, we have phase 0, and phase 3. We do not have overshoot and we do not have plateau phase if we compare this action potential with typical cardiomyocytes. But what is interesting? Interesting that phase 4, in phase 4 we have sodium influx, right? And this sodium influx coming through the funny channels, so-called funny current, or through the funny sodium channels. And in phase 0 we have calcium influx. So what's going on in case of excitation of M2 receptors and in case of excitation of beta-1 adrenergic receptors, as we're talking about sinoatrial and AV node, yeah, sinoatrial and AV node. So now we're talking about heart rate. It's important to understand that this peak corresponds to cardiac contraction. Of course, we're talking about healthy heart and everything is fine with conductive system. So the heart contraction. Yeah, so we have M2 receptors and we have beta-1 adrenergic receptors there. I'm drawing a cell membrane, the outside, inside, and we have M2 receptors and we have beta-1 adrenergic receptors. We know that normal heart rate is around from 60 to 100 beats per minute. We know that M2 receptors coupled with GI inhibitory proteins and beta-1 adrenergic receptors coupled with GS proteins, and both these receptors regulate adenylate cyclase, right? GS, or excitation of beta-1 adrenergic receptor, stimulates adenylate cyclase, and stimulation of M2 receptors causes blockade of adenylate cyclase. So really increasing in nervous vagus tone causes acetylcholine releasing. Acetylcholine interacts with the M2 receptors and slowing down heart rate. Yeah, how does that happen? Adenylate cyclase converts ATP to the cyclic adenosine monophosphate level, and this cyclic adenosine monophosphate level regulates activity of these funny channels, regulates expression of these funny channels, and also regulates potassium current. So we have regulation of funny channels, and we have regulation of potassium current through the potassium channels, and as a result of opening of potassium channels, we have hyperpolarization and slowing down in heart rate. Yeah, slowing down in heart rate. So what's going on? In case of activation of M2 receptors, we have greater potassium efflux and less amount of funny channels, and this action potential looks like that. So required time, look at that, yeah, to reach threshold level is greater, right? Is greater T2, and this slowing down heart rate, excitation of M2 receptors, or blockade of beta 1 adrenergic receptors, and vice versa. If we have stimulation of beta 1 adrenergic receptors, we have greater current and faster generation of action potentials in the sinoatrial node. What is interesting? Interesting that here rate from 60 to 100, it's kind of intrinsic rate of sinoatrial node, and stimulation of beta 1 adrenergic receptors or activation of sympathetic nervous system able to accelerate heart rate up to 200 beats per minute, and activation of parasympathetic nervous system able to slow down heart rate up to around 50 beats per minute. So we have kind of intersection of these two systems. Yeah. So let's summarize. Activation of M2 receptors in the sinoatrial node, AV node. Activation of M2 receptors decreases heart rate and causes so-called negative chronotropic effect. Negative chronotropic effect. Blockade of M2 receptors increases heart rate. Stimulation of beta 1 adrenergic receptors increases heart rate. and blockade of beta 2 adrenergic receptors decreases heart rate. This called negative chronotropic effect, and rising in heart rate called positive chronotropic effect. Positive chronotropic effect. What does it mean? Chronotropic effect chronos means time. Yeah, chronos is the time. What kind of other effects are present? So first is chronotropic effect. Second one, inotropic effect. Inotropic effect. Really, decreasing in stimulation of M2 receptors will affect atrium contractility. Not ventricles, but atrium contractility. Stimulation of beta 1 adrenergic receptors in the meat of the heart, the meat of the heart, the ventricles, increases contractility. Beta 1 adrenergic receptors causes, stimulation of beta 1 adrenergic receptors causes positive inotropic effect. Positive inotropic effect. And blockade of beta 1 adrenergic receptors causes negative inotropic effect. What kind of medications cause positive inotropic effect? We should think about, of course, it's epinephrine, norepinephrine, isoproterenol, the butamine, dopamine, etc. Negative inotropic effect, beta blockers. Third effect we should discuss is a dromotropic effect. There is a speed of conduction. And stimulation of beta 1 adrenergic receptors has positive dromotropic effect, and blockade of beta 1 adrenergic receptors causes negative dromotropic effect. Fourth effect called batmotropic effect. And this is degree of excitability. Again, stimulation of beta 1 produces positive effect. Blockade of beta 1 adrenergic receptors produces negative effect. So I hope this concept is understandable. Yeah, let's come back a little bit and let's have a look on this CMP. If we're talking about cardiac myocytes, we have specific enzyme that degrades this cyclic adenosine monophosphate, and this enzyme called phosphodiesterase. And in cardiomyocytes we have phosphodiesterase type 3. Why I'm talking about that? Because this is important for modulation of cardiac activity, as we have drugs that are responsible for inhibition of this phosphodiesterase type 3, and these drugs called milrinone, inamrinone, So they have positive inotropic effect. Why they have positive inotropic effect? Because they block phosphodiesterase and they elevate amount of cyclic adenosine monophosphate. Yeah, so they elevate a level of cyclic adenosine monophosphate by preventing degradation of this cyclic adenosine monophosphate. So really how we can modulate inotropic effect and how we can affect positive inotropic effect. In the heart. First, we can administer cardiac glycosides. Most likely you know them, like a digoxin, yeah, and digoxin blocks sodium, potassium ATPase and increases cardiac contractility. Second one, this is action related to protein kinase A, yeah, pathway, protein kinase A pathway. And first one is the beta 1 adrenergic receptor stimulation. And the second one, phosphodiesterase type 3 inhibition. And third mechanism, what nowadays we have, is the activation of sarcoplasmic pump, yeah, calcium pump. Now let's have a look in details on that. In details with example of digoxin. So let's discuss a little bit digoxin in order to better understand effects, inotropic, chronotropic effects, and this Sarco pump. So what is the mechanism of digoxin? We know that cardiomyocytes, they getting calcium from outside, yeah, from outside as a major source of calcium, and we have a specific pump. It is a sodium calcium exchanger. Sodium calcium exchanger. So what does this sodium calcium exchanger make in cardiomyocytes? It pumps calcium outside instead of sodium, pumping sodium inside. Digoxin blocks sodium potassium ATPase. Sodium potassium ATPase. Sodium potassium ATPase pumps 3 sodium outside and 2 potassium inside. As digoxin blocks this sodium potassium ATPase, we have accumulation of sodium ions inside the cell. Why we have accumulation of sodium ions? Because after every action potential, a lot of sodium coming inside. Yeah, so these sodium ions, they present in the outer surface of the membrane, and this significantly affects ability of this sodium calcium exchanger to pump calcium ions, as it's much more difficult to put more sodium inside the cell, and even present evidences that we have reversing action of this sodium calcium exchanger, and this sodium calcium exchanger starting to pump sodium outside and calcium inside. As a result of that, we have rising in calcium level inside the cell, and this is important, as increased amount of calcium causes increasing in contractility. Another interesting moment that we have sarcoplasmic reticulum also in the cardiomyocytes, and we know that sarcoplasmic reticulum is a storage of calcium, right? And In the sarcoplasmic reticulum, we have sarcopump. Activation of this pump, or stimulation of this pump, increases amount of calcium stored inside sarcoplasmic reticulum, and during next contraction, more calcium coming from sarcoplasmic reticulum and also increases contractility. But let's talk about digoxin and about effects. Digoxin produces positive inotropic effect. Why positive inotropic effect? Because digoxin increases contractility, it increases force of contraction. Yeah, force of contraction. Second one, digoxin produces negative chronotropic effect. Why digoxin produces negative chronotropic effect? Why digoxin decreases heart rate? Because in response to increased force of contraction, with help of baroreceptor reflex mechanism, we have increasing in nervous vagus tone, and we have decreasing in heart rate. This is the one way how it's possible. And second way, digoxin produces vagomimetic action. It increases nervous vagus tone. Now I'll tell you how this is possible. You know that nervous vagus releases acetylcholine, right? And as all excitable tissues, it also has sodium potassium pump. Sodium potassium pump. Digoxin blocks this sodium potassium pump, not only in cardiomyocyte but in other tissues also. And blockade of sodium potassium pump in case of nerve terminals increases resting membrane potential. So let's say it becomes more positive. Yeah, it causes a kind of depolarization. So resting membrane potential becomes more positive, and it becomes much more easier to reach threshold level. So in case of digoxin, yeah, as it's much more easier to reach threshold level, nervus vagus releases more acetylcholine molecules, and more acetylcholine molecules interact with M2 receptors in the sinoatrial and AV node, and this causes negative chronotropic effect. Also, activation of these M2 receptors in the AV node causes negative dromotropic effect. As it decreases speed of conduction in AV node. And produces positive batmotropic effect. It increases myocardial excitability. Why? By the same mechanism. Yeah, by shifting resting membrane potential to more positive level. Okay. Next, we should discuss vessels. And we should see a few words about type of receptors in the vessels. We know that vessels, almost all vessels in the human body, innervated by sympathetic nervous system, and sympathetic nervous system produces fibers, yeah, or nerves of sympathetic nervous system. They produce kind of this ampullae and release norepinephrine. So norepinephrine responsible for maintaining vessel tone. Norepinephrine. Also, we have smooth muscles in the vessels, right? And we have endothelial cells. And endothelial cells play a very important role in vascular function. So, what kind of receptors we have in the vessels? And of course, we're talking about smooth muscles. We have first M3 type of cholinergic receptors. We have alpha 1 adrenergic receptors, and activation of M3 receptors, activation of alpha 1 adrenergic receptors causes contraction of smooth muscle cells by similar mechanism. Also, we just see that we have angiotensin 2, and angiotensin 2 causes vasoconstriction. So we have AT type 1 receptors for angiotensin 2. Also, we have hormone that called vasopressin, right? Vasopressin, and we have V1 receptors. V1 receptors, type 1 receptors to vasopressin. They also link it with IP3 and diacylglycerol cascade, and also cause contraction. Stimulation of these receptors causes contraction. But also we have beta 2 receptors, beta 2, and we have D1 receptors. Stimulation or activation of beta 2 receptors and D1 receptors causes relaxation. A lot of beta 2 adrenergic receptors present in skeletal muscles, and in case of fight and flight response, in case of stress, we have a relaxation of skeletal muscle vessels, and more blood is coming to them. But what is important? To understand that endothelial cells, they have not innervated M3 receptors. Excitation of these not innervated M3 receptors related to inositol triphosphate diacylglycerol cascade, yeah, causes releasing of calcium. Calcium stimulates activity of endothelial NO synthase. Endothelial NO synthase, and endothelial NO synthase produces nitrous oxide molecules. By conversion of arginine to citrulline. And this nitrous oxide molecule, let's say the same pathway happens in another cell, right? Endothelial cells, as we have M3 receptors. So this nitrous oxide molecule diffuses into the smooth muscle cells. Diffuses from endothelial cells, it diffuses into the smooth muscle cells. And what happens in smooth muscle cells? Inside the smooth muscle cells, nitrous oxide molecule stimulates guanylyl cyclase. And in response to stimulation, guanylyl cyclase converts GTP to cGMP. And cGMP activates protein kinase G, and this causes relaxation. Relaxation of smooth muscles. Administration of exogenous donors of NO, like nitrates, has the similar pathway. But in this situation, nitrous oxide diffuses directly into the smooth muscle cells and causes vasodilation. Okay, so now we are ready to final part. We're ready to final part, and we are ready to discuss baroreceptor reflex. And we are ready to discuss blood pressure regulation. So what is blood pressure? Blood pressure is a cardiac output multiplied on total peripheral resistance. And cardiac output, it is a stroke volume multiplied on heart rate. How we can regulate heart rate? Heart rate is regulated by M2 receptors or beta-1 adrenergic receptors, and stroke volume predominantly regulated by beta-1 adrenergic receptors. What is the baroreceptor? Baroreceptor reflex is the major mechanism that regulates or maintains constant blood pressure and blood flow for every organ. And we're changing posture, baroreceptor reflex immediately maintains blood pressure, returns to normal values of blood pressure. So what we have? We have afferent part, and afferent part of baroreceptor reflex located in carotid sinuses, right, and present in aorta. So baroreceptors located in the aorta, and they located in carotid sinuses, right? Located in carotid sinuses. This information go into central nervous system, go into nucleus tractus solitarius, and in response to that, we have outflow first to the heart, let's say preganglionic fibers, postganglionic fibers, and they regulate sinoatrial node activity and AV node activity. These fibers go into the kidney, and kidney responsible for renin releasing, and fibers go into the vessels, maintain vessel tone. So how does it work? In response to increased blood pressure, in response to rising blood pressure, we have faster impulsation. As baroreceptors, they are stretch receptors, so they react faster. And in response to that, we have information going to the central nervous system, to nucleus tractus solitarius. We have inhibition in releasing of arginine vasopressin, antidiuretic hormone. As blood pressure becomes high, we have slowing down in the heart rate, right? We have decreasing in contractility. We have decreasing in renin releasing and decreasing vessel tone. As blood pressure going down, we have stimulation and releasing of arginine vasopressin. Heart rate is going up, contractility going up, and stroke volume finally going up, right? So cardiac output increases. We have increasing in renin releasing, and we have rising in aldosterone level, and we have increasing vessel tone, and all these changes return blood pressure back. So once again, in case of rising of blood pressure, we have greater stimulation of baroreceptors. They send in greater impulsation, to the central nervous system. As a response, we have decreasing in heart rate, we have decreasing in renin releasing and aldosterone level, and decreasing in vessel tone. Decreasing in blood pressure sends less impulsation to the central nervous system, and as a result, we have stimulation or releasing of vasopressin or antidiuretic hormone from supraoptic and paraventricular nucleuses, right, to the posterior pituitary gland. We have rising in the heart rate, we have rising in contractility, rising in renin releasing and aldosterone level, and increasing in vessel tone. So that's it for today. What I thought to describe. So we are done with basic things related to pharmacology, related to physiology.